Good afternoon, everyone, and welcome to today's webinar. This is Susan Ryan. I'm the Senior Director for the Greenhouse Project, and I can't tell you how excited I am for today's session and our speaker. But before I dive into that, I just want to do a few housekeeping reminders. I want you all to know that you're in listen-only mode. So if you have a question or comment, there is a question or chat box in which you can place your question or comment. Also wanted to let you know that we will reserve time at the end of this presentation to take your questions. So as you have a question, just jot it down, and then when we open it up for questions, please send us your questions and we will do our best to get them answered. This webinar is being recorded, and there will be a link that will be sent out to you a couple days after today's presentation. So today's topic is one that appropriately generates a lot of interest and a lot of conversation in our quest to create more supportive environments for those living with dementia. There are books that have been written, there are conferences, there are workshops, there are webinars, really designed to equip those of us with the appropriate knowledge and the tools and the resources to be able to do our very best to create optimal living environments for those living with dementia. So today's speaker couldn't be more qualified than Dr. Maggie Calkins. I will call her Maggie because I consider her to be a friend and mentor, but just wanted to read Maggie's bio, which I think is so incredible. Maggie is nationally recognized as a creative, dynamic leader, trainer, and researcher in the field of environments for elders. She is the president of IDEAS, which stands for Innovative Designs in Environments in an Aging Society. That's a consulting firm, but also IDEAS Institute, which is the nonprofit research institute, both of which are dedicated to exploring the therapeutic potential of the environment. That's social, organizational, as well as physical, particularly as it relates to frail and impaired older adults. She is a highly sought-after speaker for conferences in the U.S. and abroad, and she's published extensively and received over $5 million in grant funding from the National Institutes of Health and other foundations, with the express intent of developing training materials and to explore the impact of the environment on people living with dementia. I could go on and on with all the accolades and accomplishments of Maggie, but I'm really proud to say that Maggie is one of our newer members on the Greenhouse Project's board of directors, and I again consider Maggie to be a mentor and a friend. Maggie, I am thrilled that you've agreed to be with us today and that you've agreed to share your insights, your expertise, and the evidence base around designing for dementia. So Maggie, the time is yours.
Great, Susan, thank you very much. And I'm always happy to share the knowledge that I've had the pleasure of gaining over a fairly now long professional career. And I want to start with thanks to all of the people who are in the care providing world who have shared with me their knowledge and insight. I do a lot of research, and I wouldn't know nearly as much as I know if I had not been coached and tutored by the people who are actually on the front line of providing care for people who are living with dementia. So the title of my talk is the ROI, or the return on investment of evidence-based design. And I hope that that's pretty close to the end of the alphabet soup that I'm going to subject you to. And I'm going to start with a quick disclaimer. Even though that was the title, there are very few research projects that really look at the designed environment and track return on investment. So I'm going to be talking about both topics, but they often don't overlap in the same project very often. Most of the work that has been done, not all, but much of the work that has been done on sort of the business case and ROI for good dementia design and person-centered care, because I think they're related, has been conducted by the Greenhouse Project. And some of the ROI evidence that I'm going to present comes from other settings like acute care settings. And I'll tell you when it does that. So let's start with the evidence-based design topics that we are focusing on. And this is where we have the most and good and consistent research on what makes a difference for settings for people who are living with dementia. So group size, layout, orientation, building image, is it residential versus institutional in character, and then some smaller discrete studies on lighting, noise, and ceiling lifts. And if there's another topic at the end that you are particularly interested in that I didn't cover, feel free to ask about it, and if I have any knowledge of that topic, I'd be happy to share it. So let's start with group size, and it's a little hard sometimes to separate out group size and building layout because they're clearly related, but there have been some different kinds of studies that have looked at those two different topics. So, you know, we're all familiar with the traditional large hallway-based plans. This is what was built from the beginning of the Hill-Burton Act through, you know, all of the 1900s. It's still being built sometimes today, more than I would like, but the scale is coming down. So, you know, large hallway plans. You can have a hallway plan in a small plan. So this is a household type model, but it's very clearly hallway based because all of the bedrooms, which are green, face onto each other and face onto a hallway. So you can, and I'm going to be talking about different types of building layouts in the next section, but I wanted to start by showing that you could have hallway plans at different sizes. The research results, when we're looking just really at group size, larger units are associated with higher agitation and expressions of aggression among the residents, faster cognitive deterioration. So those studies that have looked at people over time show that the deterioration is faster in larger units, that there are greater emotional disturbances, it goes with the first point, and often increased territorial conflicts. And the smaller units are associated with greater well-being, more appropriate behaviors, less anxiety, less depression. You can read this list. I'm not going to read the whole thing, but clearly the benefits of group size accrue to smaller groupings of residents. And I used the term units here because with larger groupings of residents, it really is language that reflects the unit that we used to talk about. When you're talking about smaller groups of residents, I typically like to talk about living areas. Some are households, some are not, but this is, you know, the sort of the boundaries of where someone lives. So let's get into the details just a little. In these research studies, the larger units ranged from having 30 to 50 residents, and the smaller units ranged from 7 to 15. One of the big questions that I get asked all the time is, you know, is there any evidence that says 10 and 12 is noticeably, measurably, meaningfully different than 15, 16, 18, 20, 24 people? And there has not been any research that has specifically tried to compare those sized groups of residents. Much of this research on group size was done back in the 1990s when you had traditional nursing homes and then you had smaller special care units. And so the outcomes that we saw in terms of behavior and well-being and social engagement might be partly due to the smaller size, but also might be due to other differences in how a special care unit was being managed and run and the training that staff got versus how people living with dementia in a traditional integrated living area where staff weren't being given any training might be experiencing their setting, their life. So the research isn't totally clear cut, but the bottom line is all across every single study that looks at this kind of topic, the better benefits accrue to smaller groups of residents than larger groups of residents. And this is true whether the smaller setting was a household or a traditional special care unit that still followed more of the traditional sort of institutional model of care. So apart from size, how the spaces are arranged also make a difference. There isn't any sort of commonly accepted language that clearly differentiates these different kinds of sort of building layouts. I'm going to propose these. They come from a publication that I worked on about 15 years ago. So we talk about a hallway plan, an open plan, a hybrid plan, and a household plan. So a hallway plan has at least 66% of the bedrooms facing a hallway. And again, as I said at the beginning of this, you can have this in both small scale and large scale projects. The one on the left is Woodside Place from the early 90s. There are 10 people in each one of these wings, but the bedrooms all face onto a hallway and the shared social spaces are separate from that. Similarly, in the plan on the right, this is 15 years old, but you can see that most of the bedrooms open up onto a hallway that faces other bedrooms. And the social spaces, which are these orange spaces in the middle, are really sort of separate. Where's my open plan? I seem to have lost a slide. Sorry. So the open plan has at least 66% of the bedrooms that face onto social shared spaces. And I know I have some of these plans later on, and I'll make sure I point it out. And then a hybrid design is mixed. So it has not a significant majority of rooms in one or the other. This is from Creekview North at Evergreen, and you've got 3 or 4 bedrooms that sort of face a hallway, and the rest open up onto the social spaces. This is just a descriptive term. And then this is a household design. This is a greenhouse. And the household design has an arrangement of spaces specifically designed to reflect a house. So there is a front door, as there is down here at the bottom of this plan. You can see in the center of the bottom there are 2 doors that are sort of the door from the porch into the house. And then it leads to, there's a little den on the right, and it leads to the kitchen and the dining room and the living room space. And then the bedrooms are partly around that and partly separated. So it's that arrangement of space from the public main entrance to the semi-public, semi-private dining room, living room, the household space, the hearth as the greenhouse calls it, and then the slightly more private bedroom areas, and the bathing areas are also a little more separated. And so you can have household designs that accommodate different numbers of people. So again, there's overlap between size and layout or configuration. So what's the research that's been done on these different kinds of building layout configuration? The majority of the research that looks at configuration specifically looks at hallways and the paths in hallways and orientation. So are there certain types of plans that are better for residents to be able to orient themselves or worse? The results are somewhat mixed, but they, for the most part, suggest that a straight hallway an I hallway or a donut hallway offer the best orientation. There aren't so many decisions for people to have to make that lead to like dead end corridors. So most of the time in most of the studies, L or H shape plans are rated as not as good for orientation, but it's not consistent. There are some studies that suggest that L and H are better for orientation cue. And I think it probably has to do to some extent with where the location of the shared social spaces are. If the shared social spaces are at key decision points and they're easy to see, that helps with orientation. If they are way off at the end of a hallway behind a door, it takes more cognitive effort for the residents to be able to figure out how to find those destinations. There are also some studies that do compare hallway-based plans with open plans or hybrid plans. And pretty clearly the open plans, and to some extent some of the hybrid plans, have better orientation. We know that if you can see your destination, you're much more likely to be successful in getting there. And that's one of the sort of basic principles of an open or the hybrid plan, is that you can really see the destination to get there. Let's stick with wayfinding for a second, because there has been a lot of research on wayfinding. We know that that's one of the sort of functional abilities that people who are living with dementia have particular challenges with. They can't rely on their memory to create what we call a cognitive map as easily. It's not that they can't learn new spaces, they can, but some people learn them better and more effectively than others. So visual distinctiveness is important, and that's true both for spaces, hallways or spaces, but also for cues. So if your hallways all look alike, or if the cues that you're using don't stand out as being visually distinctive, it's going to be much harder for people to find their way through a space to a desired destination. We also know that cues that carry meaning can be effective. So this relates to a lot of the work that has been done at the bedroom entrance and the display cases. Familiar memorabilia that belongs to the person that they can clearly identify with. Some research has looked at a familiar self-portrait. And again, the point of this is you have to ask the person who is living with dementia what it is that they relate to. And that can change over time. So when somebody moves in, if you have display cases at the bedroom entrance or some kind of a shelf, you want to sit down with the person and put down some photographs and some objects, depending on what your space is like, and ask them to, talk to you about something. Tell me about this. And if they can pick something up and say, this is the picture from my childhood of myself and my brother that my mother took when we were on vacation, that's going to be something that they can really relate to. And if you want to use it as an orientation cue, that needs to go out front. I know in several of the buildings that I've worked in, we had some residents who were not comfortable having their sort of most treasured, recognized possessions not in the bedroom, but outside. And so when it was a photograph, we often made a copy of the photograph so they could have the original in their room and they could have a copy outside. Didn't always work, some that they didn't always remember that it was a copy, but it can help. But as I said, direct visibility is clearly been shown to be most effective, and I'll give you a couple of examples. So this is a care community that I'm doing some research in right now. These are 4 different hallways on different floors leading to different destinations. And you wonder why the community doesn't know, why the residents can't find their way around. I mean, every hallway is designed and decorated exactly the same way. They have slightly different art, but the art doesn't carry any meaning, doesn't carry any sort of value to why you're going down this hallway, what's at the end of this hallway. And I see examples like this day in and day out across the country. So if you've got a care community where, you know, your interior designer has said, you know, you don't want to have lots of different colors and, you know, lots of different patterns and things like that, you're trying to weigh the value of simplicity for operational perspective versus something that will really help the residents. And, you know, if you've got most of your residents living in a separate, segregated memory care area, that may not be as important elsewhere, but the likelihood is that you have people who are living with dementia throughout your community, and anything that you do that helps them better understand from a wayfinding perspective where they are and where they may be going, it's going to be helping everybody else as well. So having cues help. This was a lovely example in a community where the doors are recessed and everybody has this little space. So rather than just having a display case that limits what you could put there, you know, you've got a 24, 36-inch space where you could do something really creative. And this is lovely, but you do have to be able to see them. And the problem is, once these doors are recessed and you look down the hallway, you can't see any of the cues. And so it was a good idea, but they've got 3 sort of identical hallways that look like this. And if you're trying to figure out which one you're supposed to go down to find your room, and they all look like this from the main cross hallway, it's not going to help. Here's another example from another community where you've got the main entrance down here at the bottom coming in. This is a 3-story building, and the elevators that most people use are at the sort of the juncture of where the apartments are, on the left and the right. And so one of the things they said is, we have a hard time with people knowing which floor to get off of and which elevator they're using. Well, you know, I talked earlier about visual distinctiveness. This is what it looks like when the elevator's doors open on the 2nd floor, and this is what they look like opening up onto the 3rd floor. So if you're a little colorblind, you're not going to see the difference between the yellow and the green. The furniture is identical. The plant underneath the table is identical. The lamps are identical. The mirror between the 2 chairs is pretty identical. The painting is a little different, but that's a pretty subtle detail. So this was a real missed opportunity for creating a really distinctive place. And what they needed to do was to have 6 distinctive spaces, 1 at each floor, 1, 2, and 3 on each side of the building, so that people could really learn when the doors opened whether this was the floor that they wanted or not. So here's some examples of some open plans that should have been in the slide deck earlier. The red elements are the bedrooms, and you can see that as you come out of the bedroom, you can see the dining room, the living room, the kitchen directly. It doesn't take any real cognitive effort in this plan on the left. And even in the plan on the right, when you come out of your room, seeing the social spaces is very easy and visible. It's a little harder from when you are in that social space to, at least from an architectural perspective, to tell which of these 3 clusters of bedrooms might be the one that your room is in. And so from a design aesthetic perspective, I would hope that the colors or the signage or the artwork or something that you can see from the living room or the dining room and the kitchen to each one of those three groups of 4 bedrooms is really distinctive and different. And that will really help people, you know, decide this is the set of 4 rooms that I want to go to. And once you're there, you only have 4 rooms to choose from, as opposed to a long hallway that might have 8 or 10 rooms on it. So here's an example that we saw this plan earlier, where all of the social spaces are here in the center. And if you come out of your bedroom almost anywhere in this living area, you see maybe a small little sort of nook in these corners, but you don't really see the social spaces. And so there are no real dead-end paths. If you follow the paths and keep walking, you will eventually get to where the social spaces are. So it's not as bad as having just a dead-end corridor. But this is going to be a harder plan. And once you're in this dining room, knowing which one of these 3 lengths of the hallway that you live on is also likely to be difficult, again, unless there are some interior design elements that really differentiate these hallways. This back hallway is a little different because these bedrooms on the right-hand side look onto the windows that look into the courtyard, whereas the hallways on the top and the bottom look across 2 other bedroom doors. I feel like everybody should have seen these slides a million times. This is from research that I did back in the early 1990s, but when I present them and ask people, I still get people who said they haven't seen them. So these were bedrooms that we designed in a memory care program that was assisted living. All the bedrooms are private. The bathroom, the toilet is behind this curtain, so it did not have full walls and a door. And when we did research, we had we allowed 2 weeks for people to have the curtain in this closed position, and then for 2 weeks we had the curtain in an open position. And when the curtains were closed, the toilets were used 37 times. And when the curtains were open, they were used 285 times. So that direct visibility of being able to see the target destination is critically important. You will also notice in this right-hand image that the toilet is white and the walls and the floor around it are medium to dark red. So that toilet stands out like a visual beacon and nobody misses it. This is not the only way to design for visibility in the bathroom. We got a lot of people who were uncertain about it being too open and visible. Here's an example from Ohio Eastern Star, where from the hallway, you can't see where the bathroom is, but from the bed, you can clearly see the toilet. You can see that there is high contrast. Here it's blue. There's a night light above, got the wrong click. There's a night light above the toilet because when people get up at night, it is usually to go to the bathroom. And if they can see the toilet and there is a direct path and it is a big open accessible path, they are more likely to be successful going to the bathroom independently. The other thing about this design is that it has 2 pocket doors, which allows you to, for some people, if you are more functional, you may be somewhat embarrassed by having the toilet be so visible. So you could close the door that's in the photograph on the left-hand side so that the entrance to the bedroom is off of the sort of the hallway foyer space. Or if you really need the visibility, you can leave it open, and because you've got the two doors, you've got a nice wide opening. So if you're using a lift, a floor-mounted transfer lift, you have a lot of space for maneuvering. I will say that I am not happy with the hardware that they put on these doors. This hardware would be very difficult for many residents with dementia. If the door gets closed all the way, they won't be able to figure out how to close the doors. We suggested that they change that after the design. So beyond some of those design elements, the location and the design of signage is also important. And I put in this image, this was actually my father, because we need to remember that many older adults don't stand up straight with good posture, and their eyesight doesn't look at sort of, straight across and above. Their eyesight is chair rail and below. Or if you have someone who's got posture like him, he's mostly looking at the floor. So if you're putting the name of your different living areas up above the doors, up above the entrances, to say nothing of the fact that this gold on this beige wallpaper doesn't have enough contrast, they're not going to see it because it's way too high. So you want to think about putting the cues where people can actually see it, and you want to have high contrast and clear graphics, tall letters that are at least, particularly if you're looking for individuals living with dementia, that are at least 2 inches tall. And I put that last sign in, the nurse toilet sign. It has really low contrast, which is probably good for the nurse toilet, because you don't really want to be announcing to the residents that this is the bathroom that is just for staff. My preference would be not to have this sign at all. The nurses really ought to be able to figure out where their toilet is and not need to have a sign on it. The room probably has to have a room number on it for the fire emergency people. But think about what you're signing and who needs to read the signs. And if it's something that the residents need, by all means, sign it and make it clear. If it's for the staff, they really ought to be able to learn how to do it themselves. So let's talk a little about institutional versus non-institutional or traditional design. When this field really started moving in this direction, the language that we used was institutional versus non-institutional. And I questioned, and I still do question, the use of that term. And I put it here so that we could have this discussion, because you can't design the not of something. Not institutional could be residential, which is what we typically mean it to be, but it could be hospitality, it could be a beachfront bar, it could be the dog store. There are lots of things that are non-institutional, but that doesn't tell you what it is. So the language that I would suggest using is something that is more either residential style or household design. So in the research that looks at this topic, non-institutional, and again, that's the language that is in much of the research, it is defined as being home-like, enhanced, personalized rooms, domestic or residential style furniture, natural elements. It is not consistently defined across the different studies, which makes the research really difficult to interpret. It's, several of the articles sort of say well, you know it if you see it. You know what residential style looks like. But, is it enough to have, chintz carpeting and floral throw pillows on your leather Naugahyde sofa? Do you have to have 3 pillows, or is 4, what it takes? It's very hard to be very concise on this. And one of the challenges in doing research in this is that there is still, to date, not a very good assessment instrument that really focuses on a non-institutional, a home style, a household style design. There is one that is being developed now. I'm working with a Canadian architect on it. We've submitted a grant to do some good validation testing on it. So hopefully within a couple of years, there will be a good instrument that can do this and will allow us to compare across different sites the cluster of elements that seem to be related to specific kinds of outcomes. So the research results of what has been done suggest that these more residential enhanced non-institutional environments are associated with improved intellectual and emotional well-being, so less deterioration, less cognitive deterioration, greater preference and pleasure, improved functionality, which is important, less aggression, less use of psychoactive medications, less anxiety. So again, like what we saw with the smaller size groups of residents, you have all of these positive outcomes associated with a characteristic that looks more like home than like an institution. One study that was done fairly early on found that a pleasant home-like environment by itself wasn't enough, that if the policies and the procedures and the organizational structure doesn't equally adapt person-centered type values, it undermines the potential of the benefits of the home-like environment. So they looked at a number of sites that were still operating from a sort of traditional medical model, but had a enhanced environment, and they did not find those kinds of positive outcomes that I talked about in the previous slide. I put some images here that are not the really bad institutional environments that we all have seen, been in, seen it, pictures at conferences. But even so, all of these still feel more sort of sterile. The one on the bottom right, that kitchen, to me, that kitchen looks like it is a replacement for the nursing station that got taken away. And the staff get to be behind this counter and the residents get to be on the other side. This does not look like a kitchen that is inviting people to come in and, have a cup of coffee. The bedroom has, a nice printed bedspread, but other than that, it feels like a hotel. It does not feel like anybody's house. Versus these kinds of images that cry out to you, this feels like much more like a home. This one on the lower left was actually an example from the long-term living magazine competition, a remodel competition. And the before of this image looked, and I'm sorry I didn't put it in here, looked very institutional. And it's a big dining room. This is not just a small household dining room for 10 people. This is clearly a bigger dining room. But I think they've done a really nice job of creating a character and an ambiance that doesn't feel institutional. Doesn't quite feel like home because the scale is wrong. But, this bedroom is not that different than what my bedroom upstairs looks like. And this kitchen just invites you to come in and pick up, an apple or an orange and sit down with somebody and have a cup of coffee or a cup of tea. And one of the things that you can do in your own environments that is really useful is to take some photographs, because often you can evaluate a space better when you're not in it, but you're looking at photographs. So if you take photographs and print them up as 8x10s and look at them, you often have an easier time sort of saying, this really doesn't feel like what home feels like to me. So let me go into some of the sort of other research that's being done on more discrete topics. There's a fair amount of research that's being done in lighting right now. There's ambient, there's bright light therapy, there's natural lighting. There are a number of studies that have tried to dramatically increase the amount of ambient electric lighting in spaces, and most of them, there have only been a couple, but most of them generally found some positive benefits, but not wildly strong positive benefits. Phil Sloan was one of the people, and Eunice Noel Wagoner was one of the people who did, two of the people who did some of these studies. And they got some mixed results, but several studies find decreased agitation when the lighting levels are higher. The study that I was just mentioning, they brought the foot candles up to about 200 foot candles, which is significantly higher than what you will see in most care settings. Codes require hallways to be at 50, I think, kitchens and task areas to be at 75 to 100. So it was really double that. There has been some research about lighting and contrast at meals. And so in this study, increasing the amount of light and the amount of contrast in at least one study increased independent eating behaviors. So people were more independent at eating and feeding themselves, not needing as much staff assistance. They responded more on target to conversation, and their caloric intake was 1,500 kcals more over a 3-day count, so about 500 calories a day, when the menu hadn't changed at all. And so this is really important. When we did this study at one site, the staff said, you shouldn't even be doing it down here because all these people need full assistance with their meals. And once we added some light and some contrast, they were feeding themselves independently, and the staff were really just amazed. There's also been some bright light therapy using these bright light boxes, and that has been shown to reduce depression and improve quality of sleep. But most of the research tries to get people to sit in front of these boxes for about 2 hours a day. And I don't know about you, but there are an awful lot of residents that I would have a hard time getting them to sit in front of this box, for 2 hours a day. There is another research project that has been done that looks specifically at blue light. This is light that's at the 440 to 450 nanometers. It's like the kind of light that you put in an aquarium. And this is research done by Mariana Figueroa at Rensselaer Polytechnic. And when she added these blue bulbs into residents' rooms, she got a clinically meaningful reduction in depression in residents who were living with dementia. And the nice thing about light is that it can be additive. So it doesn't mean you have to sit in a room that looks like it's got blue light. You just add the blue light to an existing lighting scheme, and it will have this effect. There's growing research on LED lighting. Not a lot of the results are out yet, particularly when we're looking at individuals living with dementia, but it will be coming in the next couple of years. And there have been a number of studies that have looked at natural lighting. It's hard to separate the impact of being outside versus getting the natural daylight, but regardless, the studies seem to suggest that 20 to 30 minutes outside a day, particularly in the morning and up to sort of midday, helps to reset the circadian clock, and people sleep better at night and are more likely to stay awake and be engaged during the day. There was one other 5-year longitudinal study. Again, this is an older study, but it compared 5 different memory care programs. And in the 3 programs where the residents had good access to outside spaces and the communities tried to get people out on a regular basis, was compared with the two communities that did not have outside access. There was, over the 5-year period, more regression and a faster cognitive deterioration in those communities that did not have outside access. There has been some research on noise abatement, particularly at night, reducing alarms, teaching staff to keep their voices down, allowing residents to close their doors, does improve sleep. And with improved sleep, it can reduce agitation and improve behavior during the day. And quiet environments have been compared to noisier environments and are linked with better orientation among residents with dementia. So again, if you have a lot of residents who are expressing inability to easily find their way around your care community, stand there for a couple of minutes and close your eyes and just listen. And listen to the different kinds of noises and think about which ones can be modified or eliminated. So quickly, I'm just going to talk about some return on investment data. The research, and again, as I said, this doesn't line up directly with the evidence-based design, but the research does show that nursing homes or assisted living communities that adopt person-centered care practices experience an increase in occupancy and revenue over a matched sample of non-adopter homes. This was greenhouse research done in 2004 and 2008, where the occupancy remained stable in the non-adopter homes. It increased in the adopter homes, and there are a lot of greenhouse homes that actually have an occupancy rate higher than 89%. They're well into the 90s. The revenue increased 17% in the non-adopter homes, but Genworth Financial documented that over that same time period, that was the basic increase in room rates. So they didn't really increase in revenue beyond what the sort of the national standard was. But in the adopter homes, they increased their revenue by 21, almost 22%. And for a 140-bed nursing home, that resulted in $1,600 a day or $585,000 a year of increased revenue. There are a couple of ways that this happens. The greenhouse homes both have higher occupancy and are often able to attract more private pay residents if that's consistent with their mission. There are a lot of greenhouse homes that choose not to try to just recruit more private pay residents. The greenhouse, again, the research has shown that the operational costs are similar to national standards, but they experience Medicare and Medicare savings due to reduced hospitalizations and better maintenance of self-care. And again, all of these numbers are likely to be changing as the whole reimbursement structure changes. And there are some other ways of looking at that. So this scan report, and I put the URL for this report because it's fairly recent and it's got a lot of really interesting data, is looking at from a cost savings perspective, particularly with healthcare related costs. Are communities that are investing in person-centered care policies and practices and staff training and development receiving a return on investment of those costs? And so what they are finding is that, yes, the savings that you experience in reduced medical expenditures far exceeds the operational costs of implementing person-centered care. So a couple of the details. They particularly looked at evaluating 4 different programs listed up here at the top. And they targeted individuals who were complex, expensive. In one of the community and one of the programs only had an estimated lifespan of 3 years or less. And they saw significant reductions in admissions, readmissions, ED visits, ICU, inpatient days, specialty care, and SNF facility expenses. And so what they found was that the healthcare utilization costs fell from a baseline of 42,000 per person per year to 25,000 per person per year, which resulted in a 370% return on investment over the costs of implementing those, in their example, those 4 person-centered programs. Now, I will add that the way they calculated this is based on an organization that bears the full risk for the medical utilization costs. So if you are a nursing home and you are just sending people to a hospital, the type of return on investment that you're going to get is different. But this analysis also didn't try to include the ROI from reduced staff turnover or higher occupancy, both of which we know result from good implementation of person-centered care practices. And then the last topic, really briefly, is ceiling lifts. There's not been very much research in long-term care on ceiling lifts. One study did find fewer patient-to-staff assaults after implementing ceiling lifts and a safe patient handling program, partly because the residents didn't feel quite so crowded with, a big piece of equipment coming in and hovering over the bed. Another study found a modest reduced risk of pressure ulcers with a higher percentage of rooms that had ceiling lifts. And I did not find, go back to that, any research on staff injuries in long-term care, but there have been a number of studies in acute care that found that use of ceiling lifts significantly reduced or eliminated staff injuries from patient handling. And there are different types of units in different studies that have looked at that. So I was able to leave about 7 or 8 minutes for questions. And again, I put that Scan Foundation URL down there so that you have a little more time to look at it and write it down if you wanted to get that report. They have both a long report and an executive summary.
Maggie, this was fantastic. Thank you so much. I'm going to start reading questions that are there. And others of you, if you have a pressing question, please feel free to type it in the question box while Maggie's answering the ones that are there. So we've got a question around, it says, this came when you were talking earlier in your presentation. Does your research compare units with just individual bedrooms or apartments?
No, because when you do research, you need to have some kind of comparable group. So research that is done in assisted living, may look at a floor of resident apartments, but it then has to compare it to a floor of resident apartments. You can't easily compare, just a bedroom to a unit. So it has to do with how research gets structured.
Awesome. All right, here's one about the light levels. While higher light levels are important, your slide didn't address circadian lighting. Is that something you're looking at?
It is something that a lot of people are looking at. I am not currently involved in a research project on that. I know of a growing number of communities. It's still fairly small, but a growing number of communities that are looking at circadian lighting. For those of you who don't know what circadian lighting is, it's using LED lighting to mimic the change in the warmth of natural daylight over the course of the day. So you have warmer lighting temperatures in the morning and in the evening, and then cooler light over the course of the day. I know there are some research projects that are being done on that. The results aren't really ready much yet for public consumption, but it will be coming in the next year or two.
All right, so which light bulbs provide 200 candles? I would anticipate that this level of lighting would also benefit those living in residential homes.
So it's as much a matter of how many light bulbs and where you put the lighting as a specific kind of lighting. And 200-foot candles from an energy perspective is sort of pretty inefficient unless you are using LED light bulbs. So as the LED light bulb market and fixture grows, which it is doing exponentially right now, I wouldn't try to do it with, certainly not incandescent. It would be way too expensive in terms of energy costs. But even most of the standard fluorescent fixtures that many communities have in there, and you don't want to use a metal halide or a halogen. Halogen, again, is very energy inefficient, and metal halide has poor color rendering. So you would want to use LED lighting, and then it really has to do with how many bulbs and where you're putting them as to getting up to that light level.
Awesome. All right. It seems like all of the floor plans showed just bedrooms. Is there any research that addresses people who live in assisted living apartments?
There is less research. There is some, and Cheryl Zimmerman is the person who has really done the majority of the good research on assisted living, and particularly person-centered care in assisted living. If someone is particularly interested in that, I can probably find a reference or two on that. But there have been fewer studies that look at people living with dementia and who are in independent living or in apartments in assisted living.
All right. Here's one. I'm a care partner for my husband who has young onset dementia. Can you recommend resources that I can consult to improve our living environment in our own home?
There hasn't been nearly as much done on home environments as there have been on shared residential. And the only book that is really dedicated to that was written, I think, in the 90s, and primarily has a focus on sort of just safety. It's called Alzheimer's Proofing Your Home. And even the title tells you that it comes from the sort of the old mindset, not a person-centered mindset. If you want to email me, and I'll give you my email address in a second if people want to reach me, I would be happy. There are some other non-research related publications that I can send you the links to, but there just isn't nearly as much as there is in the shared residential. So my email, can I just get my email real fast?
Oh, please. Yeah.
And I should have put it on this page, but it's M and then my last name, CALKINS at Ideas Institute. So IDEASINSTITUTE.org. And anybody should feel free to email me if you've got questions after this, and I will see what I can do to answer them.
Oh, Maggie, and there are a few more questions in the question box. I wish we had time for them. I'm going to do one more. What is the bottom line for a gate and fencing around an outdoor space for long-term care residents? How do they go out on their own if there is a gate in the fencing, and yet it is a gate required for egress?
You can secure that gate with a magnetic lock that undoes when the fire alarm goes off. You can also design cognitive gates. So the gate opening mechanism has, 2 or 3 components that you have to do all at once, which if you're really talking about nursing home level, most of the residents probably can't manage. And you can alarm that so that you know if somebody has gone out. But the electromagnetic is probably the safest way of providing the gate, which is required, and having it tie into the fire alarm system, but making sure that it stays locked.
Maggie, a debt of gratitude to you, an incredible appreciation for what you've shared with us. I think from my perspective, we could just go on and on. I'm going to give a few remarks just to let people know about upcoming webinars. We've got a webinar on Tuesday, August 20 at 3 p.m. Eastern. It will be continuing our dementia series, and this is advocating for people living with dementia. That's August 20, 3 o'clock, and Ellett will be doing that one. And then the case of Sarah Newman. So this kind of gets into some of the design Maggie has talked about. We're going to hear from Audrey Weiner, who's going to talk about kind of a case study, what they've done at Sarah Newman in renovating their institutional building and really creating significant household designs there, and really figure out what they've done to make that sustainable change. Want to let you know about the Greenhouse Development Workshop that will be in Pompano Beach, Florida on October 2 and 3. It's a 2-day workshop. We've got all the information on our website for you to be able to register for these incredible events. And really grateful once again to you, Maggie, for sharing your time and your incredible expertise and the research that's out there. Please follow us on our social media channels, and Meg Laporte will be sending you the link to this webinar afterwards, and she will include Maggie's slides as well, so you'll be able to have those. So thank you all very much once again for joining, and again, Maggie, kudos to an incredible presentation.
Thank you.
Take care, everyone. Have a great afternoon.